of the Washington, D.C., Virginia, Maryland. We would like to welcome you to one of the sponsored webinars by the University of the Philippines Alumni Association of the Metropolitan DC. Few house rules. All your microphones are muted with the exception of the moderator, the speaker, and also would like to ask everyone to use their Dropbox to provide their feedbacks, reserve their questions later on, and we will entertain them during the question and answer forum. An overview of the event, there will be a brief introduction of the speaker, PowerPoint, question and answer, a message from the president, and further announcements. To introduce our speaker, please help me welcome the one and only Miss Maddie Rivera. Maddie Rivera, the floor is yours.
Maddie, you're on mute.
Ayan. Ayan.
Ate Maddie, you're on mute.
Sa kanila siguro. Can't hear you. Sa kanila yun.
Maddie, please unmute.
Hindi namin nadidinig.
Maddie, unmute mo siya, unmute.
Maddie, unmute yourself.
Do I have to start again, Mike?
Yes, please.
Okay, who is controlling the? Thanks
Maddie,
again, Mike.
can you hear us? Unmute
Can
you.
you see me?
Yeah.
Okay,
Okay,
Nina.
thank you. Today, we are pleased to welcome Dr. Modesto S. Rivera to our third webinar series on aging well and thriving in place. Dr. Rivera is a urologist with special interest in urodynamics and the diagnosis and treatments of incontinence, diseases of the kidney, ureter, and bladder, and men's health, including the diagnosis and treatment of prostate diseases, male fertility, and sexual dysfunctions. Dr. Rivera was a graduate of the UP College of Medicine class of 71. He did his surgical residency at the Philippine General Hospital and at the Robert Wood Johnson Medical School, Rutgers University in New Jersey. And he completed his urological residency at the Washington Hospital Center in DC. From Washington, DC, Dr. Rivera answered the call for a need to establish the urology unit of an underserved community here at Calvert Memorial Hospital in rural Southern Maryland. While maintaining privileges at the hospital center in DC, Georgetown University and Southern Maryland Hospital, he decided to concentrate and grow his practice in bucolic Calvert County, a land of tranquil living, i.e. no traffic crisscrossing the highways for him. In 1990, he opened a surgical unit at his office where he could do diagnostic procedures, cystoscopy, biopsies of prostate, bladder, urodynamics, and a few minor urological surgeries. Carrying a tradition of leadership as president of the UP College of Medicine Student Council, he has dedicated himself to authoring constitution and bylaws, medical mission protocols and procedures of different organizations, including being president of the Calvert Medical Society, the PMA of Washington, D.C., UPMASA Baltimore, Washington chapter, the Speaker of the House of the APPA, and Chairman of the National UPMASA Board of Directors. His awards include Physician of the Year of the APA, Community Service Award for Calvert Memorial Hospital, the Manggagamot Award for the PMA, and the National Presidential Award for the UPMASA. This summer, he is vested the UPMASA 2020 Community Service Award, which is scheduled from Bellagio, Vegas to another Zoom meeting here at home. What Dr. Rivera will share with us today comes from his 40 years of urological expertise. Though his topic will be limited to our theme, staying in control of your bladder, he may also be able to answer relevant questions on prostate cancer and men's health. Without further ado, let's give Dr. Modi Rivera a warm welcome and your kind attention. Dr. Rivera.
Good afternoon. It pays very well to have Maddie as my constant companion and partner in my urology office and my office practice for the past 40 years. She is very familiar with what I do, and having her here is to make sure that I give you the right information. We have a very discerning audience today, this afternoon, and I will try my best to make this hour worth your while. As I prepared this presentation over the past few days, I am also well aware that this audience belongs to a sandwich generation. You are a group of active, mature men and women who need to take care of yourselves and your older parents, as well as have children of your own to take care of.
Next slide. Tulungan ko ata.
How do you define success? For a 4-year-old, success is not peeing in your pants. Hopefully, as parents, you have succeeded in having hit toilet trained at that age. At age 12, success is having friends. At 16, it's having a driver's license. At 20, success is having sex. At 35, it's having money. At 50, success is keeping that money. Success is having sex. At 60, and at 70, being successful is being able to keep your driver's license. At 75, having friends. And at 80, not peeing in your pants. As we all age gracefully, and as one who would continue to take care of our children and look out for our aging parents, we are well aware we have found a need to be aware of what their health care needs are and how we can help. These pictures remind us of Shakespeare's The 7 Ages of Men. With longevity rising, this generation will look forward to meeting success all at both ends of the age spectrum. To empty a full bladder is one of the greatest human delights, according to Henry Miller. The act of voiding is quite natural and easily taken for granted. Henry Miller, famous for his Tropic of Cancer book series, echoes the sentiment of the 17th century Peter Bruegel. Peter Bruegel is a Dutch painter famous for his Netherlands proverb painting series. One of man's foolishness is a theme that runs through his paintings. In this one, Man Pissing at the Moon, he suggested that the endless time we spend talking about nothing is like pissing at the moon. Whether it's eroticism or bad taste, many artists have explored the act of pissing. Whether it's erotic or mischievous, voiding is certainly a subject worth painting about. Life expectancy reaches new highs. A CDC survey demonstrates that the life expectancy has increased for both men and women to about 77 years of age. It would be much longer for women. Both longer life expectancy, with both life expectancy getting longer, it is easy to forget that we are soon going to be at that age group before we need it. Older people generate more health-related costs than do younger people in their workplace. With COVID and rising infection rates in nursing homes, we begin to have second thoughts about bringing our own parents to assisted living facilities and nursing homes. Whether they do end up there, we should be quite comfortable and knowledgeable about the care that they are receiving. The cost of urinary incontinence has been estimated to be about 1.2 to 2.1 million for women in 2000, about 207,000 to 353,000 for men. In today's lecture, we will be talking about stress incontinence, urge incontinence, overflow incontinence, and mixed type incontinence. Except for stress incontinence, none of these are disease entities in themselves. However, they are symptoms of urinary incontinence. Women can suffer from stress incontinence. Both men and women can suffer from urge incontinence. Similarly, men and women can have overflow incontinence, and men can have frequency, urgency, and nocturia from BPH. What is overflow, stress, and urge incontinence? Overflow is often manifested as a small amount but a constant leak of urine, like water flowing over a dam. Stress incontinence is leakage that occurs only when one coughs or strains. Urge incontinence is leaking when one cannot make it to the bathroom in time. It's one of those, when you've got to go, you've got to go. Otherwise, you get yourself wet. This particular diagram shows the relevance of urinary frequency and reduced voiding intervals to urgency, nocturia, incontinence, and reduced volume of voided urine per micturation. Urgency and frequency are common symptoms of overactive bladder. Because of the constant need to void, the urine volume is normally small with each urination. The cause of overactive bladder is poorly understood, except in patients with neurologic conditions such as stroke, a spinal cord injury, or multiple sclerosis. In multiple sclerosis, one can have urgency and frequency one time, and sometimes the bladder goes into normal voiding cycles. But then again, it can go into urinary retention. Bladder compliance and daytime frequency and nocturia. With aging, bladder compliance decreases. Bladder compliance refers to the ability of the bladder to stretch and hold more urine. You can see in the diagram that as you get older, you get to keep lesser and lesser amounts of urine in your bladder. The muscular wall is increasingly infiltrated with fibrous tissue, which are much less elastic than normal. This would increase the need to urinate often and in smaller amounts. Both men and women would tend to see their doctors promptly if they were to come in with pain on urination, pain in the pelvic area, as in the area of the bladder, or if they would see blood in the urine. Women are quite hesitant to see their doctors. They could have frequent urination, an uncontrollable urge to urinate. They could be leaking when they cough, laugh, or carry heavy objects, or even during sex. Or they can be getting up frequently at nighttime, but they will not see their physician. They think it is part of aging, or just having children, or just plain embarrassed to ask for help. They will try to modify their behavior, and it works. Drinking less coffee, tea, and certain fruits and juices act as irritants to the bladder and can be avoided. While following a list of do's and don'ts with food and drinks, a trial of eating and drinking what is prohibited is actually more sensible, as many times one can do away with it. Drinking less often, especially after late supper, will help you get more sleep. It also helps to retrain your bladder. It simply means not responding to the urge to urinate as often as you get it. By holding it longer, you may find yourself being successful in doing so. There are certain conservative measures one can use without resorting to surgery. Women who are lacking in female hormones, as in surgical or menopause induced by a previous oophorectomy and hysterectomy, can benefit from application of female hormone creams. One can double void, meaning after finishing the first cycle, staying in the bathroom a little longer and doing it again would completely empty the bladder. Time voiding schedule means staying at intervals, trying to hold it for 2 to 3 hours, even if you get the urge to urinate. Or on the other extreme would be, if you are not aware as to when you will get the urge to go, simply go after 2 hours or 3 hours. This way, you do not get the message too late. Limiting oral fluid intake in the evening will get you more sleep, but then if it cannot be helped, using diapers and incontinence pads will be something to look for. We now turn our attention to the first disease entity which I have mentioned, stress incontinence. Weight loss, Kegel exercises, the use of a pessary, and urethral lengthening procedures are going to be helpful. Cystocele repair and repair of vault prolapse are sometimes necessary. What would cause stress incontinence? Usually, the bladder could drop, as in someone with a weak pelvic floor. The whole bladder or a portion of the uterus, if one has not had a hysterectomy, or after hysterectomy, after losing the suspensory ligaments, ligaments can cause a vault prolapse. After pregnancy, especially with a child being born at the high birth weight, carrying heavy weights or doing strenuous exercises can weaken the pelvic floor. And as I have mentioned, female hormones cause stress incontinence because there is thinning of the vaginal mucosa and loss of the mucosal folds. Conservative measures include the following. Again, weight loss, Kegel exercises, and medications. Surgery could be as simple as urethral bulking, transvaginal sling procedures, cystocele repair, vault prolapse, and open surgery for bladder suspension. Here is a diagram which explains where and how Kegel exercises would work. The goal of Kegel exercise is to strengthen the urethral sphincter by tightening the pelvic floor. This picture shows you the wrong way of doing Kegel exercise. This would only help the thigh and buttock muscles and does not strengthen the pelvic floor. This is a diagram of several of the exercises which would achieve the same purpose of a Kegel exercise. One can search the internet for exercise routines carrying out Kegel exercises. It has been reported that Tai Chi and yoga can also work. The goal is simply to identify the right muscle groups that has to move and to tighten. Stopping and starting the urine flow is not a good exercise to tighten the pelvic floor, as that would only tighten the buttocks and exercise the wrong muscle group. Properly done, Kegel exercises has been reported to be good treatment for overactive bladder as well, for urge incontinence, for painful sex called dyspareunia, fecal incontinence, and pelvic pain. There are aids available for Kegel exercises. These are biofeedback devices. I have two in this picture. The patients are asked to place the probe in the vagina, and there are sensors in the probe. And one can tighten the muscles, and one can actually see the actual pressure that she is generating. A second one is actually generates electronic impulses that stimulate the muscles to contract. So one is passive and the other one is active in strengthening the pelvic floor muscles. This particular Kegel exercise aid uses weights. There are several models available, and you do not need prescriptions to have them. The goal of the weights is for the patient to keep the probe in place. As she gradually progresses through the treatment, she is supposed to apply or put more weights and for her to keep the probe in place. As mentioned, behavioral modification can help with stress incontinence. It includes weight loss, avoiding vigorous exercise, and lifting heavy weights, as well as time boiling to avoid overfilling. In this diagram, the bar graphs on top show you various activities where physically active men and women exhibit some degree of leakage during their physical activity. Of course, if you are that lady who is carrying that much weight, it is very possible that you would develop some form of stress incontinence. Bother is the word that is used, and it is significant in terms of when do you decide you need surgical intervention. For many women, they will put up with their leakage and simply use a mini pad to keep themselves dry. This would not work for the more vigorous tennis player who would leak a small amount of urine when she serves, or for the gymnast who would lift weights. Although their muscles are already tight, they would look forward to having some surgical procedure done. Urethral suspension can be done in two ways. One, transvaginally, using both synthetic or autologous fascial slings to suspend the urethra, or openly, as in the Birch suspension procedure, to apply suspensory ligaments or sutures at the top of the bladder and urethra to keep from leaking. We turn our attention to the aging male. The aging male is challenged by metabolic syndrome, low testosterone, erectile dysfunction, and BPH. About 50% of men with BPH will develop some 50% of men after age 50 will develop BPH. About 80% of them will develop symptoms after 70, and 20% of them will require surgery at some point in time by the time they are 80. One should consider comorbidities at that age group because they are a concern as to what type of an operation, if any, that can be done. Male are concerned about the slowing of the stream, the frequent urination, the leakage of urine when they get the urge to void, the frequent urination after bedtime, the leakage of urine after voiding. This we call dribbling. And the urine stream may be stopping and starting, or it could be spraying or splitting. Men too will tend to forego seeing a doctor for health problems. It was not until PSA testing became popular in the early 90s that I started seeing more men in my office to discuss about urinary issues. Irritative symptoms, however, tend to bring the men sooner to my office. Enlarged prostate gland causes nocturia, urgency, frequency, and urge incontinence. These symptoms are often relieved using medications like Flomax, a known alpha adrenergic blocking agent. We started to see more patients after it became known that Cialis could also be helpful in relieving some of these symptoms. Men have used phytotherapy or in particular saw palmetto to relieve some of these same symptoms. In the diagnosis of BPH or lower urinary tract symptoms in men, we have to be very careful to make sure that the symptoms are prostate related, as they could also be related to the bladder, to the medicines they are taking, or to an infection or some other form of metabolic illness. Prostate-related symptoms include an enlarged gland, a prostate infection or inflammation, or prostate cancer. Bladder-related symptoms include bladder cancer, overactive bladder, interstitial cystitis, radiation cystitis, a bladder stone, or tightening of the bladder, as in bladder neck hypertrophy. Infections could be bacterial, viral, or tubercular. Metabolic symptoms could be due to type 2 diabetes, diabetes insipidus, or simply excessive fluid drinking. In this comic cartoon, we see a couple discussing why it was necessary for him to put the seat down when he is finished urinating. He was complaining that maybe it is about time his wife put the lid up after she is done going to the bathroom. As one ages, however, and the urine flow becomes weaker, slower, and begins to stop and start, split or spray, it becomes necessary for the man to sit if he does not want to wet his pants or wet his feet. Worse, to wet the toilet seat is something that the woman or his wife will not put up with. If man had to sit to urinate, the men's room line will get longer and the wait will be longer. Here we have Mac and Rowe posing for the picture. In this particular diagram, we see the significance of urethral obstruction causing an impaired bladder contractility, which makes for slow urine stream. This is a model of the bladder and the prostate. The model shows the bladder to be a ball of muscles, which would relax to a certain point to hold urine. Toilet training allows us to develop a large bladder capacity to hold urine until we can find a place where it would be socially acceptable to urinate. At age 50, most men will develop some irritative symptoms like frequency, urgency, nocturia, and urge incontinence. Often, the gland is not necessarily enlarged on rectal exam. This diagram shows the opening that surrounded by the prostate gland. It creates a ring which can narrow or choke the channel as it enlarges. Again, the weak stream will cause the man to stand closer to the toilet or to sit down to urinate, to wipe himself, or to take time after he is done urinating, to go to the john before everybody else does, so that he can take advantage of getting to the toilet stall instead of the urinal. Frequency and urgency would make him wear a pad so that he does not get himself wet, or wear dark clothes, drink less water, take the aisle seat in the movie theater, or during plane rides. He would avoid long trips unless he knows there is a restroom available during his travel. He could also be ending up sleeping in a different bed at nighttime so he does not keep waking up his wife. And he is knowledgeable about where all the restrooms are in all of the public places. The urethra can be involved and cause lower urinary tract symptoms, as in urethral infections associated with STDs, urethral stricture or scarring from previous infection or instrumentation, or urethral diverticulum, which is a pocket in the urethra. Neurologic disorders like Parkinson's disease, multiple sclerosis, having had a stroke or a TIA, or a spinal cord injury, or lumbar disc disease, as in severe arthritis or slip disc, can also cause a neurologically impaired bladder. This is the AUA symptom score index questionnaire. The questions group 7 different ways to assess bladder symptoms. A score of 15 to 20 is moderately severe, and 15 and higher would cause one to think that the patient is in need of surgical intervention. This diagram shows a much clearer way of how an enlarged gland causes narrowing of the urethra. And so would this diagram show how the urine flow is impeded or slowed down by the enlarged prostate. This busy algorithm picture shows the pathway of making the right diagnosis and presenting the right treatment option for the patient with BPH. The history and physical examination involves fairly much answering the symptom and bladder score, evaluate for non-prostate causes, examine completeness of bladder emptying as in a post-void bladder sonogram, screen for infection and prostate and bladder cancer, and select medical treatment options. We also must eliminate drugs or diet as a source of his irritative symptoms. Give the patient a trial of medicines, which include an alpha blocker like Flomax or an anticholinergic agent like Diplomate, Detrol, or Vesicare. Consider the use of Proscar, an agent that blocks the conversion of the testosterone from its inactive form to an active form in the cell. Or each time we need to consider the side effects and the cost of long-term medications of these medicines. Again, a busy slide enumerating the many medicines that may cause similar symptoms of lower urinary tract obstruction. When does a man finally decide he needs to do something? When he no longer can make it to the 18th hole without heading for the bushes to urinate as he is playing golf. One of the surgical interventions that is relatively new and available is the UroLift. It involves the placement of bolsters in the prostate gland. It will hold back the inner surface of the prostate to the side, widening the channel. These bolsters are intended to stay there permanently, and many times they would work. It does not take long for an experienced urologist to learn this new method. It is approximately a 15 to 30-minute procedure. It is done outpatient, and the patients are often released with a catheter for no more than a day. This gold standard of surgical treatment of the enlarged prostate is called transurethral resection of the prostate, or TURP. The TURP is intended to remove the obstructive portion of the gland through an instrument inserted into the urethra. The procedure can be carried out using the standard resectoscope, a cutting and cauterizing element, and used to shave small portions of the gland at a time, similar to someone scooping out a watermelon or a cantaloupe. This diagram shows what is done. The upper picture shows the loop showing clear cut vision down to the capsule. It uses bipolar energy, which allows the surgeon to use saline instead of something that may cause what is called a TURP syndrome. The end results for this method, as well as for laser surgery, are essentially the same. I have had experience using laser, using the green light laser procedure, and have had quite successful outcomes. In a TURP, this diagram shows how the prostate is kind of scooped out and the channel is widened, starting from the top, going down to the bottom, creating a cone-like opening with which the patient is allowed to urinate without losing bladder control. When the prostate are allowed to become extremely large, as we are now seeing because medical treatment is working for the most part and for so long, transurethral resection of the prostate cannot be done quite safely. It will take too long, and often a large portion of the gland is left behind. The patient is offered an open approach called suprapubic or retropubic prostatectomy. The prostate is peeled off from the capsule as one would peel off an orange from its peel. And the surgeon uses his index finger to dissect out the prostate. It will leave a very wide raw surface, which would tend to bleed right after the procedure, and it requires an inflated balloon to apply pressure on these raw surfaces to avoid bleeding. In many instances, the patient's prostate may need to be packed with actual sponges, and the patient would have to come back to the OR to bring these sponges out. For this reason, another procedure called HOLEP was invented. HOLEP uses the holmium laser. It tries to enucleate the gland. The gland is not chipped away, but actually comes in large pieces. Those large pieces are shoved back into the bladder. They are morcellized into smaller pieces and then flushed away again through the urethra. Glands as big as 250 or higher had been removed successfully by very experienced urologists. It takes a long learning curve for urologists to learn this procedure. Those who are quite successful claims they become more proficient after doing at least 40 of these procedures in their early career. We turn our attention to the second disease entity we have talked about, overactive bladder. The cause of bladder instability in overactive bladder is still unknown. However, it responds to anticholinergic agents like ditropan and merbitrate. Many neurological diseases behave in the same manner. A fourth urologic entity called interstitial cystitis will have symptoms similar to an overactive bladder. The difference is the bladder pain. The pain develops when the bladder is distended with a small amount of urine. As I have mentioned previously, phytotherapy works in some instances for the prostate gland. Here, saw palmetto, African plum, South African stargrass, rye pollen, and pumpkin seeds had reportedly been helpful with lower urinary tract symptoms. In overactive bladder, women would similarly tend to cope with their symptoms. We have discussed this previously, and the coping tricks are fairly much the same as what men would use. At the time of social distancing, as in the coronavirus pandemic, many women have found themselves self-isolated long before this pandemic because of urinary incontinence. Urinary frequency can be due to infection, use of diuretics, leg swelling, insomnia, sleep apnea, diabetes, certain foods, and neurological diseases. Treatment can be as simple as use of antibiotics for infection, the treatment of the underlying condition, as in treating diabetes, the use of medications. In using anticholinergic medicines like Diplomate, Vesicare, one should be aware these medicines cause dryness of the mouth, constipation, and cognitive problems such as hallucination, forgetfulness, and sleepiness. It is contraindicated in patients with retention of food in their stomach, uncontrolled narrow angle glaucoma, and those who are already retaining urine. For women, we have found that overactive bladders can be treated by confusing the nerves that supply stimulants to the bladder and the urethra. The nerve stimulation can be applied directly into the spinal canal or indirectly by stimulating a nerve in the patient's ankle called the posterior tibial nerve. The treatment is carried out for about 30 minutes in the doctor's office, and it's carried out 3 times a month for about 4 to 6 months. If effective, one can see changes after about a month. If none, one should consider the use of Botox in treating overactive bladder. Interstitial cystitis may present similarly, as I have mentioned, the only difference being that there is pain associated with the urinary frequency. Most of the patients are women in their 20 to 40 years of age. They may experience this problem over a lifetime. It is due to the loss of mucosal surface covering, which causes the inner layer to be exposed to urine, which is quite irritating to the bladder. Cystoscopic examination is often done to diagnose for the presence of submucosal bleeding when the bladder is overfilled, or the presence of an ulcer on the dome of the bladder, which also bleeds. A biopsy is often done to make sure that one is not dealing with carcinoma in situ. Interstitial cystitis can be treated by modifying the diet, taking Elmiron capsules, instilling DMSO, a chemical used for nursing horses with bad arthritis of the knees, hydrodistension of the bladder or overfilling the bladder under anesthesia, and in women whose bladders have contracted significantly or gotten smaller and smaller, their bladders are made bigger by applying a piece of bowel using the large bowel or the small bowel to simply make the bladder bigger. We can also alter the pain threshold by using gabapentin, the use of an antihistamine, and the use of a very mild antidepressant. Patients with urinary frequency and incontinence develop changes in their lifestyle, and there are consequences in the quality of their lives. They suffer sleep disturbances, their mobility is restricted, their work productivity is impaired, they need to be in the restroom often, they tend to self-isolate, their daily living deteriorates, their sense of well-being is impaired, their sexual function is diminished, and they overall perceive their health is poor. Patients with asymptomatic obstruction or those with overflow incontinence would develop recurrent infections, bladder infection, bladder stone, damage to the kidneys, and feeling of chronic constipation. This diagram shows food that can make you go in a hurry. Certain food products like cheese, yogurt, chocolates, apples, avocados, citrus fruits, strawberries, vegetables like onions, tofu, soybeans, tomatoes, cured meat or fish like corned beef, anchovies, beer, wine, seasonings like ketchup, mustard, salsa, vinegar, food preservatives, caffeine, drinks, cold and allergy medicine, and certain vitamins can cause problems. It is worthwhile to do a trial and test which food or drink will trigger bladder spasms and avoid them. We turn to the last treatment measure we have available or in our armamentarium, the Botox injection. Botox does not find use only in making women more beautiful, but also in relaxing the bladder. It has been found to be very effective in treating the overactive bladder, and many urologists find that it works well if offered as a second choice right after oral medications fail. The most common side effect or complication is urinary retention. The patient is advised and must be capable of self-catheterizing or wear an indwelling catheter should she have such complication right after surgery. However, the most common complaint after this procedure is a urinary tract infection, which can be treated with antibiotics. There are systemic symptoms and complications which can result from absorption of the medicine. It could be characterized by blurring of vision, slurred speech, hoarse voice, difficulty of breathing and swallowing. Many will recover soon. However, some end up being admitted to the hospital until the complications can be managed well. The urinary retention had been as long as 5 days, but some had been, during the clinical trials, required to wear a catheter or self-catheterize for as long as 544 days. The medicine is also not offered for those who are already having gastritis from food retention or retention of stomach acid. As we end up this lecture, we turn to that cartoon again. Perhaps we will convince both the boys and the girls in the group that it pays to simply keep the lid down when you are finished. As we all live longer, women should stay healthier and stay safe as we look forward to another season to attend to our illnesses and to our own parents. We find that we can socialize and laugh without fear of leaking and making it to the 19th hole to drink with our buddies and stay dry. And we look forward to not needing social distancing. After all, COVID notwithstanding. Thank you very much.
With one question, what are the common medications that causes incontinence, Dr. Rivera?
Usually diuretics will do the same, will cause urinary frequency. But I have not heard much about what would actually cause the incontinence. It is not being able to hold it long enough that one would become incontinent of urine. Of course, if one already has overflow incontinence, meaning to say the bladder cannot empty completely because it is blocked or is hypotonic, it has no bladder tone from, let's say, diabetes, the patient will begin to leak and have overflow incontinence. But it certainly will not cause overactive bladder or stress incontinence. It will aggravate stress incontinence.
Okay. You mentioned earlier about using Botox as a follow-up in case like the oral medication didn't work. My question is, how frequent are you going to use Botox injections and what's the cost?
It depends on how much or how many patients the particular urologist is seeing for that time. Usually he will need only a very small amount of Botox for the injection, but if he only has one patient for the day, he will end up paying for that whole vial. And it's already in the neighborhood of $600 for the medication alone. In all, and that was in my practice, it will be in the neighborhood of about $1,200 or so.
So, I mean,
It will be covered by Medicare and for most
Okay.
insurance purposes. Medicare, unfortunately, does not pay enough.
Well,
To
and how
cover.
long does it last? I mean, how many
It
injections?
needs to be repeated about every 6 months. It just depends on how quickly the patient wants to stay dry again, because
Okay.
like Botox applied to the face, the medicine wears off.
Okay. So again, I'd like to remind everyone to please use your chat box for your questions. Another question, as a layperson, when should I seek professional help from a urologist? This is in reference to insurance coverage. Like normally if you avail of a specialist, normally the copay is higher. So when should I consider, hey, I'll go to a urologist as opposed to my primary care physician?
It depends on how much bother you have. But if you're talking about simply being screened for prostate cancer, then again, there is no starting point. As I mentioned earlier, for some athletes who leak very much, rather leak very little, a small amount of urine leak bothers them quite a lot, especially because like tennis players who want to wear white. They certainly don't want a stain of urine in there, nor their mini pads showing when their skirts lift up when they serve. Uh, but for the most part, we have found that a lot of women and men put up with the slow urine stream. It is the incontinence and the need to stay close to the bathroom that drives them to see their doctors sooner. Of course, when they see blood, they're in the doctor's office, regardless of whether insurance will pay for it or not. Or if they have a lot of pain associated with it, they'll come and see the doctor.
Okay. I know women does breast self-examination. What would you recommend for men? Would they have to do this testicular inspection as well? Monthly?
I'm not sure what the men would need to examine.
Well, let's say, for instance, you're taking a shower and you notice like there's an abnormal bump. What should I be alarmed with? Like, is there such a thing that you have to do? Like when taking a shower, you should examine yourself as well for any abnormal growth.
Well, other than examining the testicles for a
There
bump
you go. Yeah.
or the penis for a bump, because they do have bumps that will cause curvature of the penile organ. I don't see what the men can benefit from by doing
Okay.
self-examination
So if we
of
notice
the prostate,
something like,
despite the fact that it's a very hard thing to do for men.
okay. So what's the common cause of painful urination?
Infection.
Okay. Are there any more questions from the attendees? Please, again, I'd like to remind everyone to please use the chat box.
To start out the video. The host has asked you to start the video.
I can't start it.
Hindi ako, dapat pala, hindi pala touch cam.
Okay.
Yeah, you have to do it. Yeah, there you go. Thank you.
So if there aren't any more questions from the attendees, I would like to turn in. Go ahead. Dr. Rivera, are you saying something?
Some of the men may not want to ask, but for those who are in need of surgery for their prostate, one question in the back of their minds often is, does a TUR of the prostate cause impotence? To answer that, studies done on men who've had holmium laser surgery have found that after surgery, they do not experience any worsening of their potency. In fact, some of them actually experience an improvement in their potency, meaning to say the enlargement of the prostate gland may itself be causing some degree of sexual dysfunction, and relieving the obstruction helps them regain some of that vigor and vitality.
Thank you, Dr. Rivera. If there aren't any more questions from anyone, I would like to open the floor. Please help me welcome a brief message from the President of the University of the Philippines Alumni Association. Please help me welcome Ms. Jessie Walgamori.
Hi, everyone. It's nice to see everyone again. Like Dr. Rivera mentioned, I had never thought of incontinence nor talked about it with my doctors. So, when you know better, you know better, you do better. So thank you so much, Dr. Rivera, or our beloved Diplomate, for sharing all that information with us. Another info-packed webinar. I'm so proud of our UP alumni who have been sharing their time, talent, and energy since we started these webinars. And thank you everyone for joining us. It's been a pleasure having you guys with us.
Thank you, Mike.
Thank you.
Thank you very much for also, before we end this webinar, I would like to remind everyone of the upcoming events on August 20, updates on COVID, a COVID story, COVID experience. We have our speaker, Dr. Nanette B. Kion, and also on the 25th of this month, what can I do to reduce the risk for Alzheimer's, with Dr. Patricio Reyes. Once again, thank you very much for all your unwavering support. Please continue to support our upcoming UPAA events. God bless and have a good night. Thank you.
Thank you.
Oh, alam ko nasa TV ka. Nandiyan ka lang pala. Nakakita ko.